Good afternoon. This is Dr. Garais, week 7, February 18th, 2021, and the class is MED240, Pharmacology 1. And this is week 7, topic 7, psychiatry and related drugs. And this is a continuation since we were interrupted this morning. So where were we? We went through the bipolar, lithium, neurotransmitters, and skits. Remember, skits think dopamine, limbic system, psychotics, antipsychotics, psychosis, antipsychosis. So I remember talking a little bit about this antipsychotics. The ones that I find most popular are haloperidol, Haldol, Compazine. And I did mention the Compazine, we use it in a nice little cocktail for antipsychotic patients that's the behavior is a little bit out of control. Side effects, think all of the above. The words, medical terms, dystonia and akathisia, these and pseudo-Parkinsonism, those are movement disorders. And this is one of the not so beneficial effects of the antipsychotics. And of course, I did mention this, that we use extra medication to balance and in combination with antipsychotics and all of the above, benztropine, diphenhydramine, and meclizine. These are nice things to fight these effects. And I like Benadryl a lot. And I also mentioned earlier this morning that Benadryl is utilized for also not only as like an anti-allergy medication. It has some nice effects to some of these antipsychotic side effects. Atypical drugs, I believe I mentioned this morning, really popular: Abilify, Zyprexa, Seroquel, Risperdal, and Geogodone. Big on clozaril or clozapine. You get a little bit of anemia, reduction of white blood cells, and reduction of leukocyte counts. And that's not good, because then it makes the patient predisposed to infection because they don't have enough white blood cells protecting them. Lanzapine, Zyprexa is nice. I have to concur with this. Less side effects, and it's a little bit more efficacious. And again, the overall theme of all medications is you avoid alcohol because it could have potential disulfiram effects. And disulfiram is the drug we give to alcoholics so that they have an adverse effect every time they drink alcohol, and it kind of turns them off to alcohol. I also mentioned autism, right? So Risperdal doesn't cure autism. It's a spectrum of a whole bunch of developmental disorders, and also I mentioned a little bit about what autism is. Geodone, not doesn't good regarding any patients who have any heart disease. Now, we also mentioned anxiety, and whether it is due to internal or external stress. All of us have anxiety, but if it's already getting to the point where it's affecting activities of daily living, then you need anxiolytic medication, anti-anxiety meds, and benzos and buspirone, very, 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 very effective. We also even like beta blockers, which is originally used for first line low dose antihypertensive medication, but it can also be used as an anxiolytic, or has calming effects for your anxiety patient. Buspar, like I said, really big. You can even use an antihistamine like Vistaril. SSRIs are also used. Beta blockers, Inderal, but Inderal is most commonly used for essential hypertension. It's like the first It's like the propranolol is the first drug I put you on. What's really popular? Benzos or benzodiazepine, Xanax, Librium, Valium, Ativan. These are really great stuff. Injectable is Versed. This is really potent. And remember what we talked about. If you're using a parenteral route, it bypasses your first pass effect, bypasses your liver, and it gets into your system and has greater bioavailability for effects. But very common, Valium, Ativan, Xanax, Librium, they all get abused very, very easy. And I told you guys the story about I had a DJ who loved doing Xanny bars. Xanax is, if you've ever seen it, it's a divvy dose. Let me show you what that means. It looks like this. Xanny bars look like this, and then you could like break them off 5 milligram, 5 milligram, 5 milligram, right? But a lot of people love abusing them by crushing them and then snorting them or taking them with alcohol, which has a potentiating effects, which is never a good thing. And it is, and it has a decent amount of psychological dependence, more psychological than actual physical. Something like cocaine is a controlled substance level, level 2 drug that has definite physical dependence probabilities. But benzos, in my professional opinion, is more psychological than physical. Propranolol, beta blocker, because it drops your blood pressure, reduces the heart rate. Therefore, it's good for anxiety, because what happens when you're anxious? Your heart rate is up, and your blood pressure is up. You don't take Buspar with serotonin. SSRIs, they fight each other. They antagonize each other. So if I stated that I have a patient on an SSRI and Buspar, they will do what? They'll fight each other. They're not good. They're not good together. Now, panic disorders, if any of you ever had one, they're frightening. I've never had one, but I was part of the group that induced one in pharmacology. Medical school pharmacology is very, very different than the pharmacology you're learning here. We have an extensive laboratory in medical school, because you want to, as a future physician or nurse, you want to see things happen in the real world. And we give a low-dose medication to a normal patient, like an amphetamine or something like that. You can induce a panic disorder, and you have uncontrolled, as if you can control your fight or flight stimulus. Okay. Many people, many patients, and also the people in that experiment when I was in medical school, the pharmacology experiment, they talked about how they felt like the walls were closing in and that there was a weight on their chest and they couldn't breathe. Panic disorder, differential diagnosis for that is a heart attack, myocardial infarction. Which, by the way, I was in the ER. I was all nice and quiet today, just waiting for my wife to get enough morphine in her so we can go home. There was a code. There was a MI just right next door. And gang, just a little bit of side note, and I talked this over with my mother. I asked her, Mom, did you gossip a lot and talk smack and talk garbage and when you were in the in the ward? Because I was there 5-6 hours, well, not 5-6 hours, 7-8 almost, and the stuff that I was hearing. Be a professional. Always act like there's a camera on you. And some of these doctors and some of these nurses, they just talk a lot of garbage, and it's within earshot, and I can hear it all. And also all the stuff that we've been training to you. Not a single person except for the nurse properly identified themselves. They just started talking to my wife, asking questions. And I just noticed also something, that the IDs at Inova do not, they hide your name and your title, which is weird, which I thought was odd. And there were just little things. And if you're in my MED140 class, I'll outline a lot of it. Remember the things that I also talked to you guys about, like how when the patient is in pain, don't justify and ignore their pleas. My wife is one of the hardest women I know. And when she was trying to convey the level of pain, and she's, I got tons of kids, so she knows what pain is. When she says it's an 8 out of 10, it's an 8 out of 10. And I had to stress that a little bit to the nursing staff, like, hey, she's not faking it. And I even had a nurse going, well, her pulse ox is good. Well, if I punch you in the face and you feel pain, your pulse ox will still be good. We didn't say that she had dyspnea. We said that she can't breathe. And your panic disorder, it's going to feel like you can't breathe, even though, if we do a respiratory physical examination, it's not going to say anything. So my message is, be a pro even years after you graduate. Just because you got an MD or any other alphabet soup at the end of your name, just act like a pro. And my mother admitted, like, he goes, yeah, the latest generation is not as professional as a lot of the old school people. And especially regarding HIPAA. I didn't hear any HIPAA violations, but the stuff that was coming out of some of these people's mouths, and it's very, and you guys know, those of you who work in the business, it's very unprofessional. And it's disconcerting too, especially if you're a professional and you're sitting in that ER bed. Like I said, just because you graduated don't mean you know something. So be careful of that panic disorder. And also, panic disorders, you will not see any real physical issues. Like your EKG will be normal, everything will be normal. So it's also a great way, if you're a malingerer or a faker, you want to try to get, you're an addict and trying to get some meds, they're really good at faking panic disorders. And so they're really good at getting some benzos. And then they trade the benzos for other stuff. Or they get Xanax and they trade it for other stuff. Okay? So it is an overstimulus of your fight or flight, and that's what a panic disorder is. And regular meds can trigger it, like Mucinex. Whoa, be careful. It seems like, and it's an over-the-counter drug, it's innocuous, but in something like 18% of patients, I forgot the number, but a decent amount of patients get panic attacks because of things like Mucinex. So be careful on what kind of stuff you got. So psychotherapy, right, because you want to get to the source of your anxiety, and anti-anxiety medications are usually utilized for panic disorders, PRN, or as needed. And it helps the patient to recognize when the panic attack is coming on. Sleep disorders. Now, you need to sleep a considerable amount of time, like 7-8 hours. And why? Because you got to get to this stage 3 and stage 4. Stage 4 sleep is REM, rapid eye movement, right? That's when you see, you see somebody sleeping and then they have loss of tone. That means you can move them around. There's no tone in their muscles. And in theory, they run in 45 to 90-minute cycles, and you should have at least 4 of them. And it is only in this deep sleep in stage 3 and stage 4 is that where your body, your brain specifically, starts organizing things. So pulling an all-nighter and staying awake, that's not going to keep the information in your head. Repetition, decreased anxiety, more sleep, right? And more preparation for an exam is a better way to go. And you need it. Try not sleeping for a while. The other day, I didn't sleep for 2.5 days or something. I don't know. I don't know what's going on with me, but I just felt like I just didn't want to sleep. And on the 3rd day, I was already cuckooville, right? It's good that I got some sleep last night, because if I didn't, and all that drama that we had this morning, I would have passed out in the ER. Okay, so it's usually situational for sleep disorders, and 9 times out of 10, it's stress, either in your personal or professional life. It could be pain medications. It could be a breathing problem, right? If you have a deviated septum. It could be psychiatric. Again, anxiety, depression, mania, skits. If you have all those thoughts going through your head and schizophrenia, you won't be able to go to sleep. And of course, alcohol is an overall depressant, but it's an initial stimulant, right? So if you keep on taking more and more and more alcohol, it'll keep you up until you pass out. Sleep disorders. Well, one of the things we got to do is you got to come in, you got to see Department of Neurology so that they can assess you. And then they could do stuff like a sleep study. Okay. That's when they put you in this nice like bed and breakfast style room. And then they put electroencephalogram and also other instruments to measure your breathing and how much oxygen you have during the evening. And when they do the sleep study, right, they can find all this data and then, you know, share it with you when you wake up the next day. Okay. Now, we can give you hypnotics, which is for sleep, or also known as sleep agents. But what do you try to do? The non-pharmacologic, in theory, we're supposed to do that first. And then if all else fails, we give you a hypnotic or a sleeping pill. And Valium, benzos, they're number one on the list. So what do we try to do before we give you benzodiazepine? Well, you try to normalize and schedule your sleep schedule. And nowadays, you know, there's an app for that. Increase your physical exercise. There's also an app for that. If you work out at night, right? Like, this is what my wife does. She goes to work, right? And then when she finishes work, she takes a little nap, like a little cat nap for 30 minutes. Then she gets up, right? And does what she needs to do, you know, for the kids and clean, you know, housework stuff. And then she does what? She does an hour and a half. She does her Zumba and she loves it. Guess what? And then makes her sleepy. And then you take a hot shower or a hot bath. Boom, out like a light. No alcohol. Okay, because remember, alcohol is an overall depressant, but it has initial stimulant effects enough to keep you awake. No caffeine, no nicotine, especially test taking time. These are the last two things you should be doing right before your exam. But I see it every time people start preparing for the NCLEX or MCAT or whatnot. You see them, they're like smashing down a Starbucks before they get into an exam. Caffeine and nicotine induces anxiety. You cannot put the arrow in the bullseye if you're anxious. You can be a little bit anxious, of course, a little bit worried about the outcome of the test, but overall you should be balanced, right? Sleep agents, you don't take it every day. If you take it every day, that's a problem. Also, make sure you tell the patient that you take it and do the preparation cycle for sleep. Don't take it and start doing stuff. It won't work that way, right? You have to actually prepare yourself to go to sleep. Many times, especially if I'm feeling anxious, I just sit in a dark room with no music, no nothing, just for me and my thoughts. And then I try to think of only one thing at a time. So you can see here, what kind of sleep agents, right? Benzodiazepines, class 4. We love our Librium, Valium, Ativan, Halcyon. Ooh, Halcyon, I haven't used that in a while. A little bit old school, I'm using triazolam. But yeah, but Valium and Ativan and Librium and Xanax, all very, very popular. And you use barbiturates. Some of them are class 2s. I don't like Amitol. you want to turn yourself into a drug craving zombie after a month of this? Use Amitol. I like Benadryl because it's over the counter. They're they make you drowsy because that's a side effect of an antihistamine like Vistaril and Benadryl. They make you drowsy. So we're using the side effect as the main effect, right? You don't have any allergy going on, but you take Benadryl, get a little drowsy. I actually, admittedly, when I was stressed out in medical school, I used to take a little bit of Benadryl, and then just enough to go to sleep for a couple of hours, and then get back on the line. What's neat about antihistamine, doesn't mess with your REM sleep. Sleep agents, hypnotics, Zolpidem, right? Really common. Zolpidem, also known as Ambien. Low dose Ambien is a really nice hypnotic. I've never seen it in my career, but I've heard a lot of funny stories, and also kind of scary, that sometimes hypnotics, sometimes I think it's barely like 1% of all those who take Z hypnotics, but then they start sleepwalking and doing stuff. Sonata, I never really did Sonata, but I did a lot of Ambien. Even though it's a Schedule 4 drug, there are a lot of people who get psychologically addicted to this. Now, how do we treat alcoholism? Well, again, back to, you got to go to the psychotherapy. You got to go to the groups. You got to talk to other alcoholics. Yeah, sure, you can talk to a psychologist all day, a psychiatrist all day. If they were never an alcoholic, a lot of the stuff they're going to say to you has no real bearing. But I like psychotherapy in conjunction with actual meds. And the thing about alcohol is that once that drug latches on, when you get rid of that drug, which is the alcohol, you get side effects, agitation, convulsion, but you get DTs, that's a neurologic. Delirium tremens, that's when you ever see them, they shake until they get their alcohol. They get their alcohol fix, a couple of shots, and then they're quote, back to normal. But you get DTs, that means you have a chronic problem. Now, what do we like using? We love using antabuse, which is disulfiram. And remember, other medications also have disulfiram effects. Topamax is also popular as well. But disulfiram, drug of choice. And it gives you nothing but bad side effects, especially you get these hot flashes and really bad vomiting, as in projectile, I got to get that thing out of my system. Disulfiram is very, very effective. Alrighty. That is the entire lecture, and that's the part 2. And if you have any questions, of course, email me. And again, as the last public service announcement for this particular class, if you're listening to this as a recording for other classes, I'm talking about as a public service announcement for term 1, 2021, week 8, week 9, week 10. Please inform me if you're not going to be in class, because going forward, all of the classes are now on campus. So that is February 25, 2021, March 4th, 2021, March 11, 2021. March 11, 2021 will be your final written examination. All of this is Thursday, 9 a.m., most likely in Health Lab 1, 4th floor, Alexandria campus. With that being said, thank you very much for your patience and time, and I'll see you in class next week.